Good morning. I want today discuss with you some problems related to thrombosis, especially the risk factors for thrombosis. There is no point that you cannot delete some risk factor. You cannot modify some risk factor, for instance, age, or the previous history. I mean, if you have had a thrombosis before MPN, you cannot modify this. But there are some factors that can be modified. And the factors are included in two categories. The first is cardiovascular risk factors. You see here that obesity, diabetes, hypertension, smoking, and so on, these are so-called generic risk factors. These are risk factors also for a non-MPN population. But I have to say that some of them are specific for MPN. For instance, hypertension. Hypertension is more frequent in polycythemia vera. And the reason is very simple, because a patient with polycythemia can have an increase of red cell mass, and this can increase the blood pressure. It's typical that if you do phlebotomies, you need less drugs to control hypertension. Why is important? It's important because if you see here the thrombosis-free survival, meaning that the proportion of patients who live without thrombosis, the proportion of patients who live without thrombosis and have hypertension, you see, is quite low as compared with the other without hypertension. Notice that these patients were treated with drugs to control hypertension. So this should be carefully evaluated, also because this curve has been obtained in patients at a low risk of thrombosis. So low risk meaning a young patient without a history of thrombosis. In fact, you can apply this to the low-risk category. What happens in terms of rates of event when a low-risk patient is also with hypertension? You see that the rate of events during the follow-up increases, not only in low-risk but also in high-risk patients. So this should be considered, hypertension that could be specific for polycythemia vera. Another point in this regard is which drug should I use? If you say is specific, which drug can be specific? There are many drugs to control hypertension, but there is a category of drugs that act against a system that is present also in the bone marrow, that is called renin-angiotensin system. At the end, this system produced angiotensin, and the angiotensin is kept by a receptor. So we have a category of drugs called ACE inhibitors, angiotensin converting enzyme inhibitors. This drug, if you use this drug, you get better because you need less hydroxyurea, for instance. You see here, you maintain the hematocrit at a normal level, as you like, because you have to keep the hematocrit less than 45, but you need less hydroxyurea. This is important because we know that by inhibiting the renin-angiotensin system, you decrease the production of blood cells in the bone marrow. This is interesting. Well, there is another risk factor that deserves to be treated here, smoking. Is there an MPN where smoking is particularly deleterious? The answer is yes. This is the case of essential thrombocythemia. In all the analysis we did in our series, you see among the cardiovascular risk factors and the JAK2 positivity, prior thrombosis, and the age over 60 that are well recognized risk factor for event. But if you consider risk factor singularly taken, smoking is associated with the highest risk, is very significant in comparison with hypertension or diabetes. Why that? There are some experimental models. You see here, this is an histological section showing that in acute phase, in a model, a rat model, pre-smoking, you have some platelets that can adhere to the endothelial once the endothelium is stimulated without smoking. But if you have, in the presence of smoking, you see here that this phenomenon is amplified many times. And this leads to microvascular occlusion. That is one of the problems patients with essential thrombocythemia. Please don't smoke. There are also disease-related abnormalities. Also in this case, we can modify these risk factors. First, the hematocrit. There is no point today. The hematocrit should be kept less than 45%. The PCV should be kept lower than 45%. This was demonstrated by a clinical trial. It was supposed to be important, but now we have the demonstration by a clinical trial. How to achieve 45%? You have two possibilities: phlebotomies alone, or phlebotomy along with chemotherapy, cytoreductive therapy. Which one? It depends how young or how old are you, and many other things. Well, there is now an observation. A group of scientists, clinical scientists in Spain said, look, I have seen that in patients with polycythemia vera treated with hydroxyurea, if they need more than 1 to 3 phlebotomies a year, these patients had an annual rate of thrombosis that is particularly elevated. So, more phlebotomies, more thrombosis in patients on hydroxyurea. This is very strange. So this stimulated us to see our series of patients in the database of the CytoPV trial. And we have seen that in the CytoPV trial, you see here in gray, these are the patients keeping the hematocrit less than 45. By definition, these patients had a less incidence of thrombosis because the two arms were randomized as compared with those with hematocrit 45 to 50. In these patients, the number of phlebotomies was higher than in the control arm, meaning that, this is our conclusion, is not a matter of number of phlebotomy. The problem is you have to keep the hematocrit or PCV less than 45%. Yesterday it was said here we have the drug that can control the hematocrit very well. The role of leukocyte number, that is another point that is important, well known now, and the aspirin. There is no point that aspirin should be the drug for polycythemia vera, also in this case demonstrated in a clinical trial. What about aspirin in essential thrombocythemia? Should I take aspirin? So you have several possibilities in ET. You are at low risk or high risk. Take the low risk category. In the low risk category, you can have cardiovascular risk factors or JAK2 positivity or both, or no risk factors. In this case, this is the rate % patient per year of developing thrombosis. In this case, the rate of thrombosis is superior to the rate of bleeding. Is inferior to the rate of bleeding if you take aspirin. So the recommendation is in this population, young population without cardiovascular risk factors, JAK2 negative, it is not necessary to give aspirin. And this is a good point for me. In the other cases, you see the rate of thrombosis overcomes the rate of bleeding. So it could be good to take aspirin here. And there is another point that should be considered. What happens in this category at low risk when the rate of vascular events is particularly elevated, it corresponds to the high-risk group with JAK2 positivity. So this is a matter of studies, of clinical studies. Concerning cytoreductive therapy, there is no, also in this case, we have the documentation that hydroxyurea is a drug in PV. And another confirmation of this we produced very recently. This is the thrombosis, cumulative risk of thrombosis in patients treated only with phlebotomy. And this is the cumulative risk of thrombosis in patients with PV treated also with hydroxyurea. You see here, this is a cumulative incidence that is quite lower than in this red line. But this applies not to all patients with a PV, only patients at a high risk category. So this is a further demonstration that if you are at a low risk category, you don't need to be treated with cytoreductive drugs. We have some recommendation, just to finish. In the low risk in PV, the recommendation for PV patients is phlebotomy and low-dose aspirin. Still today is the recommendation, even though there could be some subgroups of patients at higher risk. But at the moment, these are the recommendation produced by the European Leukemia Net. In high-risk patients, you have two possibilities, just to start: hydroxyurea or interferon, depending on your age. Second-line therapy. This is interesting. Second-line therapy, you can use interferon if you don't respond to hydroxyurea. But generally, hydroxyurea is given to all patients with PV. Sometimes patients become resistant or intolerant to. Then we have a drug now that is ruxolitinib that could be important in this setting. But we don't have a direct comparison between ruxolitinib and hydroxyurea. Then, in this case, the ELN decided that if you are young and you need treatment, better to use interferon after hydroxyurea. In the other cases, is recommended to prescribe ruxolitinib. For ET, we have 3 clinical trials. We don't have many clinical trials in ET. And on the basis of these clinical trials, these are the recommendations: hydroxyurea and interferon, like in PV. Anagrelide is also a drug that can be used after the PT1 results and is recommended as a second-line therapy after hydroxyurea. So, in conclusion, if you follow this recommendation, unfortunately, there still is a residual risk of thrombosis in ET, in PV, and also in myelofibrosis. Imagine that these data are data highly exceeding the rate of thrombosis that is commonly seen in the general population, until 5-6-fold higher. So we have to refine our concepts on the thrombosis by dividing properly arterial thrombosis, venous thrombosis, to look whether the two categories can have different risk factors, and according to the risk factors that you can modify today, use the best treatment in this single situation. Thank you very much for your attention.